So I'd like to welcome you all to this session on dysphagia. I think we've got 3 excellent speakers and some really interesting, innovative research to discuss in this next hour. So what I'd like you to do, if you are a participant, is please can you use the Q&A. There's lots of information coming through on the general comments, so it'd be really nice if we'll make sure we get to as many questions as possible. If you put your questions in the Q&A, then we can monitor that tab for your questions. If you could start your question with the person that you want us to address the question to, that would be really helpful. And we can make sure we direct it to the right person then. We're going to wait till the end of the session for the Q&A, so we'll have the 3 presentations first and then move on to the Q&A. So we're going to welcome to talk to us first of all Laura Ball. Laura's from the Royal Devon University Hospital Foundation Trust, and Laura's going to talk to us about a study that she has been involved in to develop a proposal for a new matrix of predictors of aspiration pneumonia, which sounds really exciting. So thank you, Laura, and over to you.
Thank you very much. I'll just share my screen so you can see my presentation. Can everybody see that okay?
Yeah, we can.
Yeah, that's coming through.
Brilliant. So thank you for all attending my presentation today on the predictors of aspiration pneumonia, a new matrix. I'm using the term aspiration pneumonia here to refer to the development of a pneumonia in the presence of aspiration. And this presentation highlights the key findings of my paper, Predictors of Aspiration Pneumonia, Developing a New Matrix for Speech and Language Therapists, which was published in August. I had immense help from statisticians Lottie Metyard of the University of Reading and Roy Powell of the University of Exeter Medical School, who is also affiliated with the NIHR Research Design Service Southwest in realising the matrix. So thank you to both of those so much. As Langmore and colleagues concluded in 1998, dysphagia and aspiration are necessary but not sufficient conditions for development of pneumonia. So let's take these 4 characters. We've got Homer Simpson and Grandpa Joe from Roald Dahl's Charlie and the Chocolate Factory, Groot from Marvel's Guardians of the Galaxy, and Hey Duddy's Toothbrush Badge Lion, Alan O'Dare. If each of these presented exactly the same in their medical diagnosis, resulting in the same oropharyngeal dysphagia presenting with the same severity, and they were rated the same on the penetration aspiration scale with a known aspiration, and they also were eating and drinking exactly the same food and drink consistencies and amounts, as well as utilising the same compensatory strategies. Given what we know or even don't know about these characters, who would develop a pneumonia and who would not, and what do speech and language therapists need to consider? Can I appropriately and accurately hypothesize that Grandpa Joe is most likely to develop a pneumonia due to his global presentation and comorbidities? Knowing this would be an absolute game changer. So from current literature and anecdotal experience of individuals that appear to be at greater risk of developing an aspiration pneumonia versus those who do not, I collated 20 potential predictive factors of developing an aspiration pneumonia. So these were broken into categories: oropharyngeal, swallow anatomy and physiology being the first. This contained weak or no cough, insensate larynx, vocal fold palsy, and swallow disuse atrophy and swallow fatigue effect. The next was nutrition and hydration, encompassing thickened fluids, alternative nutrition and hydration, and acidic food and drink. And then the final section was conditions that were transient or static, under the heading of presentation, medical history, and activity status. So the first transient presentations being current sepsis or delirium, poor oral hygiene and uncontrolled reflux. The next, transient or static, being reduced mobility and ambulation or ambulation, positioning, assistance with eating and drinking, cognition, immunocompromised, high or low BMI, and the final within this category being static conditions, recurrent chest infections, gastroesophageal components, and respiratory disease. There were 4 additional potential confounding variables: age, sex, diagnosis, and the amount of oral intake, which was captured through full oral intake, therapeutic oral trials, or quality of life tastes for pleasure. So of the 722 videopharoscopies that were conducted in the Royal Devon and Exeter Hospital between 2015 and 2022, 164 outcomes were for eating and drinking recommendations with known aspiration, and 152 of these were included in the study. Medical and speech and language therapy records were reviewed to answer 2 questions. Number 1, did the individuals develop a pneumonia, yes or no? And number 2, does the individual have any of the 20 indicators or 4 additional variables? Using logistic regression, being male was significant in developing an aspiration pneumonia, and that was in line with previous studies' findings. Age was not significant, and that was in contrast to previous studies. Diagnosis was also not significant, and as you can see, there was a broad range of oropharyngeal dysphagia etiologies captured in this study, so from adults with learning disability to head and neck cancer, stroke to respiratory, and progressive neurology to spinal. Oral intake amount was fairly evenly spread, so spread between those that developed an aspiration pneumonia and those that didn't. As you can see, of the 155 individuals eating and drinking consistencies with a known aspiration, 78 of those, which was 51% of the cohort, did not develop an aspiration pneumonia, and 74, which was 59%, did, so it's quite evenly cut. Of the 74 that developed an aspiration pneumonia, 70 of those, which was 95%, were developed within 2 weeks, which I thought was a really interesting finding. Logistic regression and random forest analysis were used to identify predictors of aspiration pneumonia developing, their weightings and their interplay. And when 18 of the predictive factors were analysed, 8 factors were shown to be significant or near significant. So here is 18 of the 20 variables analysed, because 2 variables were discounted because they made the unrealistic odds ratios, the odds ratios unrealistic. Those were poor oral hygiene, interestingly, and acidic food and drink. So with acidic food and drink, that was initially included in the study as a countermeasure for uncontrolled reflux and gastroesophageal components, because previous literature had cited that pH acidity was an associated risk with developing aspiration pneumonia. But overall, that wasn't then included in the final matrix. By contrast, poor oral hygiene was included in the matrix. The minimal cases here, I conclude, were due to speech and language therapists being involved with these patients. So there's an assumption that there was likely rigorous oral care in place due to the historic wealth of literature concerning oral care and the associated aspiration pneumonia, so that variable was included in the final matrix. Current sepsis or delirium refers to an individual's presenting condition, and current chest infection refers to previous medical history. Those were the 2 most significant variables. And then interestingly, the 3 next were laryngeal, anatomical and physiological impairments that could have coexisted together or independently, but they were significant independent variables. Swallow disuse atrophy and gastroesophageal component require further research, as they were not clear with gastroesophageal component. Further statistic analysis demonstrated it to actually not be significant, and swallow disuse atrophy with further assessment was actually inversely predictive of aspiration pneumonia developing. So that's interesting. The random forest analysis gave weightings enabling a scoring of the mean decrease in accuracy, rounded up or down to the nearest number +1 to propose the new matrix. And again, the variables are within those aforementioned subsections, and the total scores
So sorry if anyone's in this. It feels like we're having significant technical issues on this talk today, and lots of difficulties with people getting in, and now we have lost Laura for a second. I can see Lydia's popped back up again. Laura, are you with us? I can see Laura's presentation, but I can't hear Laura. I don't know if anybody from the technical team can step in and support us, please. Okay, right. If we've lost Laura for a second, I hope we can come back to where she's talking about the implications. She's got another couple of minutes to talk to us, so that would have been frustrating if we can't get her back in there. What I'm going to suggest, if it's okay with you, Sophie, if you're online.
Yep, I'm here.
Should we move ahead with your presentation? I'm so sorry, everybody. Let's put that back in there. So, Sophie, we all know Sophie, don't we? So Sophie is a lovely speech therapist from Manchester University, and Sophie is going to talk to us about a scoping review that she's done to explore the assessment and terminology for laryngeal hypersensitivity and all the variations that are in there. So, oh, I can see, look, Laura's just popped, now Laura's popped back in. Laura, do you want to just finish off you've got 2 minutes left of your presentation. Now you're back in. Should we hold our fingers tight and that you can pop back in and carry on?
Let's see.
Let's go for it, Laura. Let's see if we can carry on.
So can you see that? And can you hear me?
Yes, we can.
Yes, we can.
Okay, perfect. So I was talking about the implications being timing SLT input and dysphagia therapy, and providing an example that if somebody had a significant transient presentation of sepsis or delirium, introducing therapeutic oral trials with known aspiration may be justified in the presence of the potentially of seeing or evidencing swallow disuse atrophy, which is, again, I've said, a factor that requires further research. And this could be halted, though, in favour of continuing dry dysphagia therapy until the rehabilitation improves swallow efficiency and airway protection, and that would depend on the individual's goals. And we would wait then for the current sepsis or delirium to be treated, with the view that this would reduce the likelihood of developing an aspiration pneumonia. The matrix could support individuals to make eating and drinking and rehabilitation decisions, and demonstrate clarity in speech and language therapy decision making. So this study was a retrospective cohort service evaluation, and it utilised real-world data. This meant that the study had a small sample size and was from only one institution. And this had an impact on some of the variables. Again, the disuse atrophy, there was only 7 instances. 4 did not develop an aspiration pneumonia and 3 did. And as I've said, this is a really interesting variable with big implications on early speech and language therapy intervention. And in fact, if it does inversely predict aspiration pneumonia, that would be really interesting. Video fluoroscopy was brilliant in that it enabled us to know if an individual aspirated, but that cohort then had limitations. For example, sitting balance, although there were individuals in a Tilton space wheelchair, this could have been underrepresented. And although sepsis and delirium was statistically significant, alongside cognition and assistance, these again were likely underrepresented due to the nature of video fluoroscopy. Consciousness and mechanical ventilation were not captured, and they've been highlighted in previous studies, and again that was because of the nature of VF. Tracheostomy was not analysed despite the individuals in the study who had or had had both temporary or long-term tracheostomies. And previous studies had actually concluded that tracheostomy was inversely predictive of pneumonia, and tracheostomies were not significant. Away from video fluoroscopy, quantifying the amount of aspiration is a challenge, and the matrix needs to be validated. So that takes us finally to the future work. Does the matrix work in practice? This needs to be a much bigger study. Further research is required on those variables of interest, and transient respiratory diseases need to be captured in the matrix. So sorry about those technical issues. Thank you so much for coming to my presentation, and I look forward to any questions later on.
Thank you so much, Laura. I'm really sorry that we messed up your presentation with the technical issues. So apologies. I think we've got some amazing questions for you, so we'll wait until that comes in and at the end of the session. I'm going to move on to Sophie. Sophie, we're lining you up. Okay, so I partly introduced you. So just a refresh, Sophie's going to talk to us about a scoping review to explore the assessment and terminology for laryngeal sensitivity. Thank you, Sophie.
Wonderful, thank you. I think we just need to take a second, just everyone breathe just for a minute. What a stressful afternoon. Okay, let's lighten it up again. Okay, so individuals in my practice sometimes ask me, why did it take so long to understand my symptoms? And in this session, I'm going to talk through how I used patient and stakeholder engagement, a scoping review, and a research priority setting task to better understand laryngeal hypersensitivity in dysphagia difficulties or swallowing difficulties. And I'd like to thank the work of Fiona Gillies and Sarah Wallace in helping me do this. So I'm Sophie Chalmers. I currently work at the Manchester Airways team at Manchester University Foundation Trust, predominantly with people with laryngeal hypersensitivity, inducible laryngeal obstruction and cough hypersensitivity, but I have a clinical background, strong interest still in dysphagia and voice disorders. So what's the situation at present then? So we have clinicians reporting referrals of unexplained swallowing difficulties with co-occurring laryngeal sensitivity. Researchers have also attempted to coin these concurrent symptoms as muscle tension dysphagia, but we're not really sure how helpful this has been in clinical practice so far. Patient healthcare journeys show long times between symptom onset to diagnosis, particularly between primary, secondary and tertiary care settings. And often it's with this lack of acknowledgement or validation of these symptoms despite the social and emotional impact. And so for clinicians, there's a lack of evidence around the diagnosis, assessment and treatment of these difficulties. And this may lead to inequity of service delivery and treatment, but also uncertainty for us as clinicians and also our patients as well. So who are we talking about? What cohort are we talking about? Well, these are patients where mechanical, structural, neurological causes for swallowing difficulties have been ruled out, either through ENT, respiratory or gastroenterology colleagues, or jointly with SLTs as well. And instrumental assessments of swallowing typically show typical swallowing presentations, but despite this, patients continue to report coughing when eating and drinking. It feels like it's getting stuck, it feels like it's going down the wrong way. I can choke sometimes food comes back up, and I start avoiding things that trigger me. But also they're concurrently reporting things like throat sensitivity, a feeling that there are lumps in the throat, sometimes some associated voice changes, throat clearing, and some upper airways dysfunction as well. Within the context of laryngeal hypersensitivity, if you view this on a spectrum of how this manifests in terms of breathing, cough, voice, and of course what I'm talking about today, swallowing. So we have manifestations such as globus, throat clearings, muscle tension dysphonia, chronic cough, ILO, and of course here, swallowing. But let's hear from a patient. So everyone please cross your fingers. Let's hear from a patient about what these symptoms are truly like to experience.
Picked it up and I took a mouthful and I realised it hadn't gone down because I was being a bit cocky last time I spoke to Sophie. I said, Sophie, I've done away with my straws, I'm drinking out of a glass, and well, I don't know if it's because it was pop, because I don't drink pop. It didn't go up, it didn't go down, it just sat. And then I realised I was choking or drowning or whatever it's called, nothing coming in or out. And I try and do it with my tummy muscles like a self-Heimlich manoeuvre. And it came out, stuff came out of my nose, out my mouth. But then I realised I still wasn't breathing. I had the foresight to get off the chair and sit on the grass. Next thing is, apparently I was out cold. But I have never been that scared, because for about, I don't know how long it was, a minute and a half, no breathing at all. And I was looking at my friend, and I had my hands up to her saying, help me. And she said, if I hadn't have lived through that with you, I wouldn't have believed it.
So these people know they have these symptoms, they're experiencing the cold hard truth of them, but our instrumental assessments are pretty much normal. So where do we start with a research head-on?
Picked it up and I took a mouthful and I realised.
So we've started with our clinical conundrum. And where I went on from this was patient and stakeholder involvement. So I had 3 patient individual discussions about what this meant for them. We had 3 expert SLTs in upper airways and dysphagia involved in this, and the scoping review. And I had an interest group of 9 speech therapists as well. And I spoke to all different kinds of speech therapists in clinical community teams, those with experience in voice and upper airways and dysphagia. And the aim of the patient and stakeholder group was to get their input for the review questions and focus, but more essentially putting these findings into the context of their expertise and experiences to then go on and identify some future research priorities as to where we can go. So the scoping review. So this was the most appropriate way to use a structured method of reviewing the evidence, because it provides that exploration of the breadth and depth of these complex concepts. So the aims of the review were to explore the differences in terminology and assessments used in this population. We screened 2,590 titles and abstracts. We full screened 88 papers, and then 17 went through to the final review stage. In terms of context, these were the broad contexts that the papers were set in. So as you can see, the majority were either ENT or SLT, or indeed a combination, followed by only a handful in respiratory and then 1 in neuro and gastro contexts. So for terminology, there were 7 different terms used across the 6 studies which specifically discussed terminology. And as you can see on the screen, some of them I have never used in my career as a speech therapist. Some I've never heard of. But in those papers, the ones in pink are the ones that we used in a speech and language therapy context. The The ones in blue were the ones used by ENT. Only one in green, which was a swallow-related cough, which was used by our respiratory colleagues. And then in a neurological context was these two terms here. 11 of the studies focused on assessment, and of these we could group these into swallowing assessments, laryngology assessments, gastro and respiratory assessments. So the most common tests were video fluoroscopy, FEES, and a timed water swallow test, followed by endoscopy and video stroboscopy. And most assessment tools were described to rule out medical diagnoses which may result in an oropharyngeal dysphagia. So essentially to rule out your mechanical and structural dysphagias through instrumental assessments. And this exclusionary approach to clinical identification is consistent with, say, a functional dysphagia from an esophageal point of view, but actually it's inconsistent with more recent guidance, say, from Baker and colleagues, which aim to identify positive clinical characteristics to rule in diagnoses as well. There were very few assessments that ruled in positive clinical identificators in this population. Of those that did, there were only one or two coming through. So laryngoscopy was able to rule in laryngeal muscle tension if it was a co-occurring symptom. In this population, FEES identified premature swallowing and multiple swallows. There was a paper that stated longer swallow times in this population, but actually on looking further, that was still within the typical limits. So following these findings, I presented them back to the patient and stakeholder groups and completed 2 rounds of research priority setting. And these were the priorities that our patients and SLT stakeholders came up with. So the 4 top ones you can see were really exploring key clinical features, to evaluate our practice on a national level, to develop an agreed working definition, or at very least an umbrella term, and also to co-produce an assessment framework so clinicians could actually be guided as to what to look for in this particular cohort. So even though scoping reviews are really for exploration of a topic and finding evidence gaps, is there anything we can take away clinically from this? How do we interpret this in practice, I suppose? So like these trio of dancers here, we have now an awareness that laryngeal hypersensitivity can manifest as voice, swallowing and airway difficulties. And actually most people have 2 or more of these manifestations. So really, we shouldn't be treating these in isolation. There's no specific guidance on how the diagnostic workup should be choreographed, but it's likely formed through our dysphagia best practices in instrumental assessment and the use of our MDT members to rule out causes, structural, neurological causes of dysphagia. There's also no guidance as to what we call these set of symptoms, but in practice, we are tending to use creative descriptors to aid communication of the symptoms. We absolutely need to acknowledge the quality of life impact and the broader impact of these symptoms. These people might not have an identifiable mechanical dysphagia. They might not be aspirating. They might not need modification, diet and fluid modification, but we absolutely have a duty to investigate and use our voice, swallowing and upper airway colleagues within and between services to help unpick this more. So there's ongoing work in this field, so keep an eye out as to what's going on. And I just want to finish very, very quickly with this short and cheery clip of a patient who I worked with on her swallowing, laryngeal tension and sensitivity. She obviously consented for me to sharing this with you because she really wants to spread the word. I won't play it all, but you get a sense of what's going on here. And I'll skip to the end because this is the cheery part. And I'll leave that thought with you. Thank you.
Fabulous. Thank you, Sophie. That was great and well within time. So marvellous. We're catching up. Okay, so guys, can remember to keep putting your questions in the Q&A part. Just start it with the person that you want the question addressed to, please. Got some lovely comments coming in. Hopefully, we've now got 175 people in the call and we're all in and we're all sorted. So on to our last but definitely not least, Lydia, you're with us now. You've got your presentation. Lydia is a speech and language therapist who works in a research unit, and Lydia is going to talk to us today around a study she's done using a wireless CTAR ball with feedback for the patients with older adults in an acute setting. So over to you, Lydia.
I've just realised it's saying it's not detecting my microphone. Can you hear me?
We can hear you fine, yes.
Okay, fine. And then the other problem is that my presentation is now not showing on here. I'm so sorry, I've had so many issues. I'll try and re-pull up my presentation and see if it then comes up as an option. Joys of IT.
Do you want us to give you a minute to find that, and I can maybe pose a couple of questions while you find it? Is that helpful?
If you give me 1 second, I think I'll get it. Yeah, that's, oops. I think I'm nearly there. Sorry. Actually, maybe I thought.
Should I do that?
Oh, wait a minute.
Okay. Well, we can ask a question. Oh, you're there.
I think we have. Can you see that?
We can see that, and we can hear you. So off you go.
Perfect. I'm so sorry. Got there in the end. Hi, I'm Lydia Morgan. I'm a speech and language therapist, and I'm also a researcher at the Bristol Speech and Language Therapy Research Unit. I was a research associate on a secondary site for this study, so the Bristol site, and the primary site was Lewisham and Greenwich, who are the sponsors for this study. Just to acknowledge that this study was funded by the NIHR, and it was a research for patient benefit study. And it was a large research team that worked on this project. David Smithard was the chief investigator and mastermind of the study. We have a number of other co-applicants and co-advisors there, statisticians, and the other primary research associate on the study was Aoife. And I just want to say thank you to all those who participated in this study. So, as we probably all know, the population is a growing elderly population. It's getting older, and swallowing problems are common in older and frailer populations. Studies suggest a prevalence of around 30% of swallowing difficulties. This is higher in those with other comorbidities and those who are acutely unwell. Dysphagia is obviously known to cause a lot of secondary issues such as malnutrition, infection, as well as loss of independence. So it's an important thing to work on. And one approach to swallow rehabilitation, or indeed maintenance of swallow function, is to improve the strength of the suprahyoid muscles. There's two types of key exercises that do this. You've probably heard of them both. One of them is shaker, which involves isometric head lifts. And there's evidence that this improves swallow mechanics. However, shaker can be difficult to complete, especially in frail and elderly populations. Another similar exercise is called chin tuck against resistance. So chin tuck can be completed by pushing the chin down on a partially inflated ball or something similar. A recent systematic review of 9 studies and 8 meta-analysis found that chin tuck against resistance, or CTAR, was actually found to be more effective than shaker at improving swallow safety, as well as increasing oral intake. However, previously, exercise interventions have not been carefully able to control the effort involved in chin tuck, or the level of squeeze, and the ability to consistently control one's own effort during rehab is obviously essential in order to undertake the exercise in a consistent and regulated way. No previous Exercise programs also have allowed the logging of exercise data for subsequent review by therapists in clinic. So the research team designed this sort of small size rugby style ball, which allows the level of pressure that's exerted during the chin tuck squeeze to be monitored by a small pressure gauge. So the pressure gauge is the small ball at the top there. This exertional pressure can be sent to a monitoring and display device such as a smartphone or a tablet, and this provides feedback to the participant. So by adjusting the level of effort exerted in squeezing the ball, the participant can match a predetermined safe target, and the feedback system ensures repeated periods of chin tuck exercise are performed by the patient or participant at a safe and consistent effort level each time. The bar shown here on the right is how this looks to participants. So the fact that it's green is showing that the correct level of effort or squeeze is being applied. If you're pushing down too hard or not pushing down hard enough, that would go red. So the aim of the study was to explore the feasibility of undertaking chin tuck against resistance with feedback to improve swallowing and food intake in older adults presenting to hospital with pneumonia. So it was a feasibility study. The specific objectives were to establish if it's feasible to recruit enough participants, to assess the willingness to participate and complete the study, to assess their compliance and explore outcome measures, and also to assess the ease of use and acceptability of the intervention. The inclusion criteria was that they needed to be admitted to hospital with a diagnosis of pneumonia, which is where they were recruited, was on the hospital site. They needed to be medically stable, so they had to have a new score of 1 or lower. They had to be scoring as clinically frail. Most of the participants were over 75 years old. They had to have adequate cognition to be able to consent and participate in the study, and they were screened on the MOCA cognitive screen to ensure that they had a score of 14 or greater. They also had to not be on oxygen and have no past history of neurological disease, as well as no evidence of severe rheumatoid arthritis that might impact their ability to complete the chin tuck. So the exercise schedule involved, first of all, asking participants to complete their hardest chin tuck or squeeze. So the software then set the target pressure at 30% of the maximum chin tuck strength, and that was the target level. There's 3 groups, and participants were randomized to the 3 groups. So the control, which was usual standard care, none of the patients were diagnosed as dysphagic, so there was no active treatment in that group. Participants in the low intensity rehabilitation were asked to complete 3 sets of repetitions of chin tucks for 1 minute, and then in between there was 1 minute rest. So 1 minute chin tuck, 1 minute rest, 3 times over, once a day. The high intensity rehabilitation group was the same, but they were asked to do that twice a day. So 3 repetitions of chin tuck, but 2 times a day. So there was 2 recruiting hospitals. One of them was Bristol, one of them was in London. The rehabilitation lasted for 12 weeks. That was how long they were doing the exercises for, every day for 12 weeks. Home visits occurred every 4 weeks, with multiple questionnaires and measures of swallow function conducted every 4 weeks, as well as at baseline. So as I said, there was a 12-week intervention period, and then there was also a 12-week follow-up period post-intervention where participants were still assessed every 4 weeks as well. Now, we had aimed to recruit 60 participants, but in the end we recruited 24 and were able to randomise 21. We had a number of issues with recruitment. Some of this was due to delays with COVID, sort of delaying the study, and we had issues getting my site started actually from a clearance perspective. It was also felt that the population was more unwell post-COVID, and that it was harder to find those patients that were well enough to be recruited to the study because patients were more unwell post-COVID. Certainly I found that recruiting people in the acute who were frail and in hospital but were not considered medically unwell and had sufficient cognition as well as no neurological background, quite a difficult inclusion criteria to meet. So the problem was often in finding participants that were suitable for the inclusion criteria rather than that they weren't interested in participating. So of those that were suitable, around a third of those approached were willing to participate in the study. Just under half, however, completed the study. And again, that was largely related to health reasons. Again, I think because we were recruiting a population that had just had a pneumonia and were by definition frail, they kind of tended to have some quite significant ongoing health needs. There were some other reasons as well. Some of them were kind of device related, and some participants felt they had too much on, but certainly health seemed to be the kind of primary reasons for not completing. There were a lot of questionnaires, as I mentioned, but the kind of main ones, or the ones that I'm going to give you an overview of today, were the following ones. So the EAT-10, which is an eating assessment tool. It's a symptom-specific outcome instrument for dysphagia, and it consists of 10 statements that a patient rates on a scale of 0 to 4. So with 0 being no problem and 4 to being a severe problem. There was the 4QT, which was a much smaller tool of just 4 questions that was designed to identify dysphagia. And we also screened patients on the functional oral intake scale to have an idea of if they were modifying their diet. And again, none of the patients included in the study had a diagnosed dysphagia. So for the EAT-10 scores, just to show you, there's 3 groups at the top. So the control, the low intensity, high intensity, they were the groups. And then along the bottom, we have the time points. A score of 3 or higher on the EAT-10 is meant to give an indication that there might be some swallowing problems. And the EAT-10 actually goes up to a score of 40. So you can see that their scores are low here. The kind of baseline scores indicate that on average there may be some mild dysphagia, but certainly not high levels of dysphagia, low levels overall. And you can see again the numbers in brackets indicate the number of participants in each group, and you can see that certainly, particularly in the low intensity rehab group, but across the groups the numbers are quite small. So we can't really use this to kind of do a statistical analysis or kind of scrutinize it in detail, but I'm kind of showing it to you to just show the trend that it kind of seems that patients have low levels of dysphagia overall, and that there's some improvement by 12 weeks across all groups, possibly a slight uptick again at 24 weeks, but again the numbers are small, so it's hard to say. And the results were similar for the 4QT as well. So on the 4QT, a score of 1 or more is generally used to indicate there may be dysphagia. And this was fairly consistent with the EAT-10. Again, low numbers overall, just about kind of scoring around the 1 level at baseline. And then these numbers seem to be dropping a bit and maybe slightly upticking again at the 24-week mark.
2 minutes,
in terms of functional oral intake, so 7 means total oral diet with no restrictions, 6 is total oral diet with multiple consistencies but no special preparation but some limitations, and 5 is requiring some preparation or compensation. Again, across here I don't really see any clear patterns. Most patients were managing on a total oral diet. At the start of the study, perhaps some of them were having some special preparations, but mostly it's sort of these fairly flat across groups that most people are managing on for full total oral diet. In terms of other outcomes, it was found that the mean chin tuck strength increased by approximately 21% from the baseline to the 12-week point. It was also found that participants were more easily able to maintain the target effort. So that kind of keeping it in the correct range as they were completing the chin tuck would improve. They was better at keeping the right level of squeeze or pressure. There was also a trend towards improvement on the SCORCOL, which is a quality of life assessment, and that was across all groups. But again, the numbers are quite small. In terms of patients' experiences of using the device, as we've already noted, there was a high dropout rate, but this appeared to be most frequently due to ill health. And as I said, recruiting patients who by definition are frail and had pneumonia meant that they were often ongoing issues. Most participants were quite positive about using the device, then they were happy to be taking part. They did struggle a bit more with the technology and the technical side of things. We provided the participants in nearly all instances with a tablet, and that was quite novel to a lot of them, and they needed a lot of assistance with that and understanding it. Some of them also had problems with that eyesight that made it difficult for them to kind of navigate around that. We conducted interviews with some of the participants as well. 4 participants had full interviews, and in those interviews it was demonstrated that the kind of hospital period was a bit of a confusing time, and the memory of recruitment and the details about the study, why they were doing it, what it was for was quite sketchy, despite being given written advice and it being explained, etc. So and there was kind of evidence of ongoing cognitive issues, even though they'd passed the cognitive test, but you know, kind of indicating that this population maybe needs a bit of extra support with understanding what they're doing and why they're doing it. So to conclude, this is a difficult to recruit and retain population, as mentioned before, and a lot of this we felt was due to them being in the acute setting. And as you wonder if a community sample would be a bit easier to recruit to. This study was not directly looking at a dysphagic population, and I think in that context it's probably quite hard to look at the change on those measures of dysphagia. But I think it's useful to look at this population because they can be an important population for working on maintaining swallow, as we know that dysphagia increases as they get older. There was good indication of participants being able to use the device and improve at using the device over time. This study is one of the first to allow patients and clinicians to safely monitor chin tuck intensities and maintain them in a consistent and targeted way. So I think there's good evidence there that we need to further look at this device and using it in a larger scale study, as well as looking at a study that more directly explores the effectiveness of it, not just whether it might be feasible. And that's all. Thank you so much. It's just a slide about the speech therapy research unit.
Thank you, Lydia. Okay, right. We've heard from 3 excellent speakers there. We've got some amazing comments come through and also some questions. Speakers, may I ask you just to keep yourself on mute unless you're responding, just to prevent some of the feedback that we're having. So if we start off with Laura, some really good questions in here and really valid points about we need to get this out there. So what are your thoughts on how we can get the message about the matrix out for use in clinical settings?
Yeah, I think that's a bit challenging at this stage. So obviously the matrix is published and was published in the European Archives of Otolaryngology. So you can see it there. Because it was technically a service evaluation specifically to one institution, it requires further research to be generalizable, which is problematic at this stage, but hopefully something that I can work on with some funding and as a bigger research project in the future.
Thank you. So Fiona, that's answered your question about where we can see that published. So that's great. Thank you very much for that. And can I just ask you something, Laura? Would you see this as being possibly developed into kind of a risk assessment on admission into a service, such as when a referral comes through, you may use the matrix in order to determine the priority that a patient needs to be seen? What are your thoughts on that?
That's a really good question. I hadn't intended it to be used as a risk assessment and more as a management tool to facilitate and support speech and language therapists bringing together all of that global assessment that we do with each individual patient. That could certainly be something that would be an additional piece of work out of this, but as the matrix stands, it's for those that are known to be aspirating and giving that information to the person and the wider MDT as to what we could anticipate the outcomes specifically to pneumonia for that individual. So not a risk assessment in this instance per se.
Okay, thank you. We'll move on to a question, I think, for Sophie next. Kate's asking, what are your recommendations for this group of patients currently? Good education, reassurance, validation of their symptoms, and this ties in. A few people have asked about, you know, what do you do next when you understand this? What are the treatment or intervention options?
Yeah, it's a really difficult question without having sort of robust evidence base at the moment, because essentially what we're going off is anecdotal reports of what we're all doing, which is part of the kind of consensus piece I'm trying to draw together. But yeah, all of those things. So education is absolutely key. You know, understanding something that's so abstract to patients, you know, it doesn't often make sense, this kind of concept of sensitivity. Validation, 100%, no matter what they think their trigger was it a previous stressor, was it a viral infection, was it prolonged years of vocal use, no matter, or even if there isn't anything, validation of that symptom is obviously going to get you that rapport that we were talking about in one of our keynote sessions. If you think it's sensitivity, then addressing sensitivity, and you can go back to kind of some of the evidence-based and voice work around desensitizing the larynx. And if you have seen laryngeal tension there, if you have had the opportunity for someone else or your service to scope them, then you could work on laryngeal deconstriction techniques if you think that's contributing to their presentation as well. So a bit of a combination of education, validation, and obviously some laryngeal work as well.
Thank you. And really valid point, we don't all have access to instrumentals, and it feels like we need to go through a process in order to rule out other things before we come up with a diagnosis of laryngeal hypersensitivity or whatever one we want to pick from your list. In the absence of instrumental assessment, what might you recommend? And somebody else is asking around, are there any, through doing your research, have you come up with any trigger questions that will really help you to dig deeper? So I wonder if you can talk about those two aspects.
Yeah. I mean, the first one, I absolutely acknowledge that not everyone has access to instrumental assessment. And obviously that's something ticking away in the background that everyone's kind of working towards and striving towards. But in the absence of that, you know, going back to our core dysphagia skills of our red flag symptoms are going to be at the forefront of your mind if you're working with someone like this, and having quite a low tolerance to those as well. Second of all, that kind of in-depth clinical case history and life history, keep reverting back to that so you can match up what the patient's saying with their clinical history, their case history, their life history, and keep refreshing that in your mind, because you might find that things pop up that point you in a slightly different direction later down the line. Third thing, I think we probably don't do this enough in speech therapy, but getting together as a team to discuss these cases. So if you think you've got a differential diagnosis sort of there, discuss it with people, because other people might offer a different opinion depending on their background, depending on whether they've got a more acute respiratory background or whether they've got a more community neuro head on or something like that. So we can't know everything. So I think particularly in this population where missing things is really not an option, getting together with other speech therapy colleagues to discuss the cases is crucial. And then the fourth thing, and this is mentioned in a paper by a research group in the States, Kang and colleagues, in their 2021 paper, is in my reference list. They suggest that actually you could do a treatment trial of desensitizing the larynx and reducing laryngeal tension if you think that's what's going on. And if you're not making progress, you know, again, have a very low tolerance for suggesting onward investigations through your medical colleagues, depending on what co-occurring symptoms they've got on. So that's the practical advice that we've all got to deal with on the ground. The second bit of the question was around, remind me.
Oh, I've moved on. It was around what, so we don't have instrumental assessments. Can we assess it in other ways? Trigger questions. What kind
Trigger
of
questions,
trigger
yeah.
questions
Trigger
can we
questions.
ask?
Yeah. So nothing came out of the research, so it's very non-specific. I mean, the first problem we've got is identifying this population in the first place. So there's no research that's really been able to gather all those people together and ask them, what's going on for you? What does your symptom profile look like? What does it feel like to you? So we don't have that. So I can't really answer that question necessarily, apart from the things that I put on the slide. So the co-occurring laryngeal sensitivity, throat clearing, globus, voice changes, maybe some upper airway dysfunction, alongside the coughing routine, drinking, choking, particularly on an intermittent basis. Usually if there's something like a structural mechanical dysphagia going on, it's usually more consistent than this population we're talking about, anecdotally again.
Okay, thank you. And last question for you, Sophie, and I'm not sure whether there is an answer to this or not, but Emily's also alluded to it around functional dysphagia and laryngeal hypersensitivity. Is there a continuum? Is it completely separate? There just seems so many parallels. Can you add any light to that?
Yeah, I mean, what a difficult question. What a difficult question. I think my thoughts are it's more of a continuum. I just get that feeling that it is more, it's less distinct than our nature wants to make out. And I think, you know, as the way as most symptomologies are going, is sort of phenotyping these types of symptoms, I guess, into subsets. But, you know, we're really not there yet. But yes, we've got different cohorts in different medical specialties. So like I said, the ones coming from a neurological background, through a respiratory background, which is predominantly where I work, and also the laryngology background. So there's lots of different parallels going on, but they are all interconnected, which is why I said at the very beginning, we can't start isolating symptoms, and actually we do just need to treat this as a whole and use each other and our knowledge that we've got together.
Absolutely, thank you. And Lydia, just a comment really from myself. Anybody who attended the keynote speaker with Rojani talking about adherence, and generally adherence between 22 to 52% is what Rojani was quoting, and you had 45%. So actually, that's really quite good, actually, isn't it? So you know, thumbs up for that. But have you got any thoughts on what you could do if you really wanted to bump it up from going through this process? Is there anything else you think, you know what, if we just did that, we might have got a few more people?
Yeah, I think a lot of it was the population that we were picking, and I think a community sample rather than an acute setting sample would have been better for getting a larger population, but also that we're more inclined and healthier to do it, that were still frail but weren't acute, you know, having just come from a pneumonia. I think that made it difficult. The participants really fed back that they did enjoy the home visits, and I think that helped that we were going to them, even though we still had those issues with retaining them throughout the study. But I think that I mean, I guess it's expensive running things that way, but I think that making it easy for participants and going to their house, and some of them really kind of enjoyed the social side, I think, of having that contact, and also repeat explanation about what we're doing. And I think they needed a lot of reminding and a lot of guiding through using the technology side, and I think it was really important for it not to be too overwhelming for them. It's sort of surprising when we asked them questions how little some of them understood with all the written information we gave them, and I kind of got the impression they weren't really reading it. And I think a lot of repetition. I think it was hard as well, because when I was trying to recruit, I was kind of mindful of that we shouldn't be pressuring people into doing it as well, and it's kind of wanting to get enough people and wanting them to do the study and being encouraging versus not feeling that you're coercing people, or also if they want to withdraw, that is their right to. And I think that's quite a difficult balance to strike, with kind of, you know, ultimately if people want to finish for any reason, then that is up to them, kind of thing. But yeah, I think that patient contact and going to them, and I guess them understanding the benefit maybe a bit more than we were able to communicate, would also be a strong factor.
I think there's some really valid points there for any aspect of the work that we're doing with patients.